Okay, so today we'll be discussing our interspinous plate device called InSpan. We're going to go through a couple of topics here. We're going to go through the product technology itself, some symptoms, diagnostic, and patient selection section, as well as going through the technique itself and some highlights as far as things you want to look at and things you want to focus on when going through this system. First and foremost, the indications for use. So InSpan is indicated for spine fusion, non-cervical spine fusion, T1 through S1. It's indicated for spondylolisthesis, trauma, and degenerative disc disease, and is intended for fusion as a non-standalone device, unless you're using it with bone graft. As far as some features on the implant itself, so the implant itself really focuses on the anatomy of the spine. The engineering team here took a look at every single detail as far as the spine and how we can best distract that space, because ultimately what you're looking for with a device like this is the most distraction that you can get at that surgical site. So if you take a look at the bottom edge here of the implant, you can see that it's perfectly contoured, and so this allows it to sit very nicely against the lamina, so you're able to really drop it down as anteriorly as possible to get down as far as you can to get the utmost distraction that you would with the hubs here in the center. So that's a really nice feature when looking at the implant. The implant itself is offered in multiple sizes, so it's able to fit the needs of the patient and the surgeon using it. So you go from sizes from 8 millimeters all the way up to 16. So that's 8 and 16 being the maximum distraction and foraminal relief that you get. In addition to that, the implant itself really highlights wanting to fixate onto the spinous process itself. So the spikes are engineered so that when you compress on the implant itself, you're really able to get a really nice bite on the spinous processes, ensuring that that implant won't migrate post-surgery. The spikes themselves are staggered so that the spikes don't interfere with one another and cause a stress point that could cause some sort of fracture or some sort of issue further down the line. And as far as the implant, when you go to insert it, you're able to get compression on either side of the implant, highlighted by those circular cutouts that you see in this image here. So in those circular cutouts, you're able to use the compressor instrument, which you'll see in further slides, to really feel like you're compressing onto that spinous process before final locking this device. So the surgeon can really squeeze on it and then really get a nice rigid feel when compressing these two implants together. In addition to that, our implant design is actually the same implant, it's just mirrored. So it's got 2 set screws at the top here, and so when you drop down those set screws, you have double the fixation onto the hubs, ensuring that the implant will not migrate or come apart once the surgery is over. As far as the history with the implant, this implant has been FDA cleared since 2010. We've implanted more than 3,500 devices and have had over 2,500 cases done with 0 device failures, which speaks to the ingenuity and the engineering behind the implant itself. Dr. Adenos, if you'd like to go over the symptoms and diagnosis section.
Sure. Who are the doctors here that are on the conference call with us? Do we have pain management? Can y'all hear me okay?
Yes.
Are they pain management guys, or are they neurosurgeons or orthopedic surgeons, or a little bit of both, or who do we have on the call with us today? Anybody? Okay. Is it, well,
Ratan, Ratan can, I think, Dr. Annagnost, we have, I think, two or three pain doctors,
okay.
and we have some people who want to understand, like Deanna Smith and Randall Alexander. They are few of our distributors, like Dr. Rodriguez. I think, Ratan, you know, based on what they have filled, you can, there are two or three pain doctors, right?
Perfect. No, just curious what our audience is today.
Yeah,
so,
the audience is mixed. We have pain management physicians. We've got professionals from pain management domain, and definitely we have quite a few of distributors who wanted to kind of participate and learn about this product. They're from various cities and kind of various sectors.
sure. So those of you who have used the device, and maybe no one's used it at all, but hopefully you all have used some sort of interspinous device of some type, whether it's this or not. But I think those indications are going to parallel no matter what you're using. But you'll find that the InSpan device really outshines, in my opinion, just due to the strength, the ease of use, the simplicity of it. It's so easy to use, and it does such a good job. So we'll get to that, but understanding the symptoms, it's really one of my favorite patients are going to be the spinal stenosis type patients. They've got a combination of a little bit of back pain with some neurogenic claudication and radiculopathy. So, and patients who aren't so healthy that you don't want to, remove too much of the lamina or whatever, do too big an operation. And so these fit really nicely into practice. So it's like a perfect pain management scenario. Those guys you're doing injections on and they're just not getting better. The injections stopped working because the stenosis has worsened. So, all you really need to do is, those neuroforamen are so collapsed down, get a device in that's just going to open those things up, where it opens up these neuroforamen, and the patients do so well with that without, I'm an orthopedic surgeon, so, I know how to fuse and cages and everything. This is taken over my practice as far as I do so few pedicle screws now and cages now. I'll use this and I find, hey, most people aren't going to need anything else, especially the elderly population. Does that make sense? So let's go. So the indications are very, very broad. I wouldn't do this just for back pain. It can be. I tend not to do too much back pain surgery anyway, but almost all my patients have a component of course, back pain, radiculopathy, and stenosis with some component of back pain along with that. And the nice thing about the device, and I apologize, I've got an office full of models, and all my InSpan models and everything are at my office that I work in. But the beauty about this device is it's so strong, and the fixation that it allows, it actually helps with back pain, because so much of the back pain that happens, there'll be facet arthropathy, and these things are going to widen and they begin to grind. And because it is a fixation device, along with the distraction device, and it fixes it so well, it stops that grinding, and so the pain from that facet pain, that motion, really lessens. And so it covers both bases quite nicely. Let's go to the next slide. So I think we all understand lateral recess stenosis. I think that the MRI kind of shows it, kind of a classic L4, L5. The stenosis, you can see the widening of the facets there, and the fluid and air in the facets, and of course the foraminal stenosis as well as the central canal stenosis. And then again, looking at this model, you're going to see how those foramen that are collapsed, just like that MRI shows, by just getting in there and distracting that device, just what happens, with the indirect decompression is very impressive. So it fits well into the hands of a pain management person or a surgeon. Whether you decide to get in there and remove some of the lamina as a surgeon, or you rely on the device to do the work, it's gonna help the patients. And then of course you have the facet degeneration. We talked about the actual fixation of the device really helps with that grinding of those facets and the facet arthropathy that's present. Okay, that's very important. These things on this slide are all very important in keying into your diagnosis, and luckily the InSpan device really touches and addresses nicely each one of these things. All right, let's go to the next slide. I think we all probably understand stenosis itself, but the understanding the facet is often overlooked. So, and the screen, my screen's a little bit blocked on the right side of the facet versus the left side of the facet. It's no big deal. I think, you know, the arthropathy of the facets changes. You know, one side will change from the other, and you can see the orientation of these facets becomes much more from a sagittal to a coronal plane. It's going to come around as we come up the spine, but it's critical, you know, the stop gap that it happens across the lower spine, of course, at L4, L5, where you're going to have most of your surgeries. You know, it allows to stop that subluxation or spondylolisthesis, whereas when these things begin, you have the facet tropism and widening, you get way too much motion in that neuroforamen as well as the collapse, and it begins to bang and cause a lot of pain. And to cut to the chase, this device addresses those things very nicely. But I'm sure you all appreciate the facets as you look at your MRIs. If you don't look at your own MRIs, I would encourage you to do so. It's very, very important, not relying just on what the radiologist says, but looking at that MRI, looking at that facet, and see if it correlates with what you're seeing on your physical exam. Is it an L5 radiculopathy? You know, on the right side is worse from the left, and then you see the tropism is worse, the stenosis is worse on the right compared to the left. It makes you feel better. Okay, I'm on the right track. You might do, you know, injections in those areas with some temporary relief. And then you feel good that, hey, I can maybe do a targeted InSpan device at 1, maybe 2 levels. And that's the bulk of my practice is most of it's 1 level. I'll just go after the worst level for them and kind of leave the other ones alone and see if I can't get those patients good enough without, you know, trying to swing for the fences every single time and address all the pathology all over the MRI, because then you're just doing too much stuff. So I would encourage you to find that worst level and address that with the InSpan device, and I think you'll be happy. And I explain to my patients, we may have to come back later if another tire blows on your 18-wheeler. You know, we'll have to come back and address that. But right now, we're going to get rid of that worst tire for you. You know, and the bulk of what I do is going to be at 4.5 and, you know, 3.4, some at 5.1. Okay, next slide. This looks like a busy slide. I'm probably not smart enough to understand and look at this. So, I think it's common sense. Stenosis can be such a big part of what you have. Don't be afraid if there's a spondylolisthesis that you can't handle that. By opening this area up, you're going to relieve a lot of that spondylolisthesis. As long as it's not a pars defect, you're okay. And of course, this addresses the facet tropism. So all those things that you see in the second column there are basically addressed with the ISP device. Let's go to the next slide, please.
Yeah, and just to add to this slide for a bit, this is basically just a flow chart of the different scenarios that you can have and the different use scenarios that you would have for this device itself. So like Dr. Anagnos mentioned, you have things like stenosis, spondylolisthesis, and facet tropism, and sort of what you'd be trying to accomplish as the doctor, as a surgeon, to alleviate the pain for that given patient. And I think we're going to get into the surgical technique next. But before we do, is there any questions around the implant features or anything that Dr. Ananas has discussed that anybody would like to ask before we move on?
Yeah, and we would like to encourage as many questions as you have. We have a really great participation. We really want to thank once again for everyone to join. We have Dr. Patel. Dr. Patel, thank you so much for joining us. If you have any questions, please. I'm really sorry about the confusion about the link to join in, but we're glad that you can make it. So please help us. Let us know if you have any questions. We also have Dr. Mansfield. If you have any questions, please let us know. Dr. Selvin, you're welcome to share us any questions that you have. We'll be more than happy to answer.
Yeah, and please interrupt me anytime you guys want, because I've put in probably hundreds and hundreds, if not close to 1,000 of these implants probably over the years. So I know a lot about it. I've used other products as well, and I know some of the differences between some of them that I can help you with as well. I mean, I think this is an excellent product, not just because I helped with the design of it years ago, but it's so simple and not over designed, and it's so amazingly strong. The instruments are very easy to use and intuitive. So please feel free to take an opportunity to pick my brain and Maybe you know more than I do about it. Love to hear what you guys do as well, but don't hesitate to just interrupt. This is very casual. That's why I'm wearing a t-shirt. You want me to go through the technique, or you guys want to go through that? What do you want?
Well, I can go through the technique. Thank you, Dr. Ananas.
Sure.
So yeah, like Dr. Ananas mentioned, as I go through this technique, please feel free to give any questions, anything that can make it more clear. But to start off, we're going to incise in between the spinous processes of interest and cauterize as necessary and retract the incision site. Next slide, Oscar. So after retracting, one of the points that I want to make about this procedure is that it's very has a lot of direct visualization. So part of the LES philosophy is that we want to limit the amount of fluoroscopy you really need. So upon getting your incision site and removing, you want to remove the supraspinous and the interspinous ligaments, and that's going to allow for you to drop this the two InSpan plates in between the spinous processes.
So Daryl, if I could add something, I mean, this is a nice MIS incision, and as I've gotten better through the years, I've made my incision smaller because I understand the implant. The difference is mostly cosmetic. I mean, you can really make a decent side. You don't have to make such a tiny incision. Your first case or two, go ahead and make your incision a little bit bigger, the order of 3, maybe even 4 inches, and you'll identify the level correctly. You'll be able to test the spinous processes by pushing and pulling. You'll see the collapse. You'll kind of gain a little more comfort level. So don't struggle with the incision. And then secondly, taking down the ligament, I highly encourage you guys to go to a lab that we might host. Some of the procedures that I've helped adopt and improve over the years were really, what helped me the most was going and seeing some surgeon who knew all the pearls and had made all the mistakes, and he can kind of tell you, he or she can tell you all those things in a short little, couple-hour weekend course where you're together and you don't have to reinvent the wheel. So with that being said, some of our pain management colleagues, we were kind of nervous about taking down the ligament. We can show you a lot of tricks and tips of that, not to be afraid in the lab. It's critical to doing that. In the early days, we talked about trying to pierce the ligament from each side and distract with the ligament intact. I'm a big believer in taking the ligament down so that this area can open up. It's such an important part of the procedure for this to happen. So it's a safe thing to do in the hands of just about anybody. So you just got to learn a couple of tips and tricks. And Daryl may go through some of those. I'll have my cell number and emails for any of you guys that might think, hey, I'm not sure what to do or whatever. You guys can call me anytime. Sorry to interrupt, Daryl, but I thought that was important to mention when you just talk about taking down the ligament and seeing the incision size. Please go ahead.
No, absolutely. Thank you, Dr. Ananas. So as Dr. Ananas mentioned, we want to get the distraction between these two spinous processes, and this next step involves using a distractor, really, and it's really a sizer for the implant that you're going to use. So what this allows you to do is you can really get a tactile feel for exactly how much distraction you're going to be creating. And you can see on that right image there that the top has a readout. And when you start getting that tactile feel, you can correspond that with the number up top there, and that'll tell you what size implant that you want to drop down. And I can relate that size to the next slide when we start looking at the implant as well.
Yeah, and if I can add something to that too. So the way the distractor is engineered, you're actually able to drop this down and leave it in place. And so what that does, I know Dr. Chin and Dr. Ananas do this quite often. They'll leave the instrument down and sort of relax the area that they're working in so that when they put the implant in, they're not fighting much tissue or muscle. And so, leaving it there for a few minutes and then pulling it out once they know what that size is very beneficial to the technique.
That's a critical little pearl. I'm sure most of you all know it's called ligamentotaxis. So you get in and you'll stretch that. And I often put in the biggest implant. I'll go with 14, 16 almost all the time. But you'll start off a little bit smaller, but I would encourage you to learn to get a bigger implant. You'll learn to machine a little bit with a rongeur, those little spinous processes. But just putting that thing in, putting it down nice and deep. Now this distractor is nice and low profile. It fits in, and it's amazing some of these companies have designed, because this was designed in 2010. It was FDA approved in 2010. So this is 10 years old. We've made some improvements along the way, but even the newer technologies, it's funny when I look at their instrumentation, I'm like, why would you do it this way? Why would you make something so big and bulky that's hard to fit in there? These are nice, low profile instruments that you can see around, that aren't like putting a tire iron in there where you can't see anything. So using this and sizing it up is really critical. Go ahead, please.
And so our next step, after getting that distraction and the right size implant identified, we'll assemble the implants onto the inserter, and that works pretty much by a threaded inner stylet or inner shaft that'll thread directly onto that implant to get that connection, and you'll do that for both sides of the implant construct. Now, after you have both sides of this construct assembled to their respective inserters, you can see on the images on the left there that there's a pivot mechanism that really allows for you to bring these implants together along with the inserters, so that you can just drop it down right into the space that you've removed the supraspinous and interspinous ligaments. So like Dr. Ananas mentioned before, you can, after, once you've relaxed some of the ligaments in the area, you can just drop this down right onto the lamina, and you may be able to tell from this image at the top there, but the implant is designed so that it contours to the lamina. This way you can really maximize the amount of depth that you get on this implant during insertion, and it really just, like I said, contours to the anatomy very nicely.
And if I can add something further to that. So again, speaking to the simplicity of the design of the instrumentation is super important, right? As you guys are able to see, we have, 5 or 6 instruments, but just every single detail. So even something as simple as that locator pin, what that allows you to do is assemble these implants together, not having to worry about the bottom or getting your glove caught if you were trying to assemble these, at the distal end. So if you marry these pins together, you're able, that the implants will be assembled, and you're able to just drop them down. So just little details like that, make a world of difference when going through this technique in the OR.
So after you drop that implant down into the interspinous space, you then will compress on the implant directly. So you see the first step there, that on the left there, that you'll compress onto the shafts to kind of start that compression process. Then you'll have 2 compressors that meet with the two holes, or the 2 little divots on the implants that Oscar had mentioned before. And with that, once again, you really get a tactile feedback as to how much compression you're placing on those spinous processes, and that's going to help a lot with limiting your range of motion in the various planes. But once again, after compression, it really can feel the spikes going in there, and as Oscar mentioned before, that they're staggered, so it really disperses that amount of force and gives you a great fixation.
So if I could add a few things,
Sure.
These things seem very simple. You're like, okay, well, that's pretty obvious. It's when you look at the different devices that are made now with interspinous, there was hardly anybody making interspinous 10 years ago. And there's a lot of devices that are out now. It's amazing the poor quality engineering that has gone into the instrumentation. These little notches that are on the side of the implant, the InSpan itself, that the compressors fit into, it may not seem like a big deal, but it's a huge deal in doing this correctly, because those things will fit in. And you'll see several of these devices that are out now, and they're smooth. They have compressors that are smooth. They don't fit in. They may only have 1 compressor instead of 2, and you don't get even compression. With this, it fits in the hole right where it's supposed to be, and you can slowly begin to compress based on osteopenia and that kind of stuff, and get the thing in. The second thing that's so important is, if you don't like where this is, you can take the compression off and lift it off, right? It's pretty obvious. for instance, what is it? The zip system or whatever by Aurora. That's another competitor system. But the engineering behind that, if you guys have ever seen it or done it, is actually quite difficult because the zip is on a ratchet. It zips together, right? Once it locks in, you're stuck. You have to go in there, and to get that thing done takes another level of college engineering to get that thing undone, to get it to release, okay? And that's just not what you want to have to deal with while you're in the OR. You want something simple. And the simplicity of this implant is that they simply married the exact same mirror image. They took, if you look at the device, one side is simply flipped around. It's exactly the same as the other side. So the simplicity of that allows this actually to be a simpler device, a more intuitive device, and it just makes better sense instead of this over-engineered like Minuteman or Zip or these things. They've made these incredibly elaborate, complicated devices that frankly they're more difficult to put in. So this is a great system to start with. It's a great system just to continue to use. And the tools are very, very well engineered. And I think you'll find them extremely intuitive. Again, because if you get it in there and you're not like where you are and you look at your fluoro on your lateral, you need to be a little deeper, just release it a little bit and open it back up. Impact a little further down because the way this thing is recessed so nicely, it's going to fit down nicely low. The engineers have done a nice job with that. You like where you are, take your clamps again, clamp it in, and you're done. Go ahead, please.
Great, thank you. So after you've gotten the desired compression and you got that the great AP depth that you're looking for, you would then final lock the construct. And really all that means is that you'll take a screwdriver for the set screws that are on each of the implants, and you'll lock it to the to a torque. And you're going to be limited by exactly how much torque you can put on with a torque handle. So you'll get an audible and a tactile feel as to indicate so that you know exactly when you've reached that right torque. So to have confidence that the implant will provide the fixation that you're looking for.
When you finish these, go back to that last slide. So this is what I do, and when I do the labs that I run, we probably have some video of this somewhere, but I'll take those two clamps, the silver clamps that you see, and I've locked everything down with a torque wrench. And can you guys see me? Because my video isn't on. I don't know if I'm trying to show you all what's going on, but I don't know if you can see my video or not.
No, we can only hear you, Dr. Ananas.
Is that something that I need to click on, or you probably don't want to?
Yeah, it should be either on the lower left-hand side or at the top of your screen. You'll see a little video camera with a red line going through it. Just click that and it should.
Oh, there we go. Okay. Yeah. Okay. I was sorry. I was trying to explain all this stuff to you and show you what was going on with the models and stuff. And I apologize because I didn't know my camera wasn't on.
No worries.
But what I was trying to tell you is I'll put those clamps in, those silver clamps that you see. They're locked into place. And that's when I go ahead and tighten with a torque wrench like they just explained. You can take those silver clamps, one in each hand, and I can lift the patient almost off the table, okay? And you sound like, oh my gosh, whatever. That's how strong this thing is. And that's how the teeth are so well designed with all this. But it's a nice thing to do. If we do a lab together, glad to show you. But also, I think getting in the habit of doing that and getting in your mind, okay, this is what I'm really doing. I'm putting in as big a device as possible to really help open those neuroforamen and distract them open like this. That's a key part of the operation, is to open that area up, putting in a big implant that comes down and then locking into place. And then it's strong enough because it's made for a fusion device that you can lift this thing up and lift the patient up off the table. Go ahead, please.
And then finally, there's opportunities for supplementing this fusion with bone graft, either in between the spinous process plates themselves, or you can also add it to the facet joints as well.
And this is important for our pain management colleagues who are doing things like, gosh, what's the distracted, the X-stop kind of device that everybody uses?
Vertiflex?
Yeah, it's like, the difference between this and Vertiflex is amazing. And I've done a few of those cases because I work in a pain management office 2 days a week. I work with a guy, Dr. Patel, and he's got a great practice, and I've learned a ton from him with what he does. but I've learned to appreciate this device compared to Vertiflex. And I know Vertiflex has done such a good job of marketing and getting out to you guys, and it has its place. But this does so much. This does so much more. It does Vertiflex and so much more of what it does because it is a fixation device and because it is a fusion device. And so dropping that graft in, I'll usually lean over through the same incision to harvest a little graft from the iliac crest, but you can just use nanofuse and DBM, put those things in there. Not only does it help with your billing codes and that type of thing that you're doing a fusion, but it helps with the stability of the device. And that's key in the long run because this is initially a fixation device and a distraction device, but ultimately we want this to become a fusion device where the bone will regrow across there and then it will take the force off of the implant and the biomechanical stresses will be on natural bone, which is important. And it's not going to be a fusion like you think about with pedicle screws and rods and cages and all that kind of stuff. It's more of an elegant, technically, yes, these will fuse together and you want them to, but it's such a better way to do it than what most orthopedic surgeons are out there doing every day. And what you guys see in your pain management clinics, you got to know about when they come back with pedicle screws and rods and cages, the difference is night and day between this procedure and that procedure. And I'm an orthopedic surgeon, I do that procedure, all the time. I just prefer to do this. Go ahead, please, Daryl or Oscar.
Yeah, so that's it for the technique. This slide here is just showing some data from a follow-up outpatient results. Really showing the decrease in reported pain. And important part to mention here is that all surgeries were completed in less than 1 hour. Which is great. Definitely a focus of our company and of the doctors we work with is emphasizing that LES approach and minimizing the amount of time that the patients really have to be exposed to the surgery and getting back to their quality of life faster.
Key point, very important slide.
And the same thing here. I believe this was just done at another level, but once again, just showing the difference in pain scores from pre-op to post-op and 2-year follow-up. And once again, just emphasizing the speed of the technique and just allowing these patients to get back to comfort really faster than ever. And that's it. Like Dr. Enos and Oscar have mentioned, if there's any questions, please feel free to voice them, and we'd love to clarify some things or get some opinions.
Yeah, and I mean, we really want these webinars to be interactive, right? This is your opportunity to ask any questions, no matter how simple you think they may be. If we have the data, we'll certainly share it. If not, we'll certainly follow up. But please take the opportunity to ask whatever you feel you need to.
So I might ask some of the physicians out there. I mean, one, has everybody at least tried either this implant or something similar to it? And then those of you who have, did you struggle at all? Was there something you liked, you didn't like about the system you did or didn't use that we can maybe just discuss and talk about? Again, because I've done hundreds and hundreds and hundreds of these cases. I can learn from you guys, just like hopefully maybe you can learn from me, but I'd like to hear what's easy for you all and what's difficult for you all from the perspective of our pain management colleagues. Anybody have any comments or questions they can talk about cases they may have done? It doesn't matter the system. I don't care, whatever it is.
For myself, I'm a 4th-year resident that will be starting pain next year. So it's a little early for myself, but just have been kind of staying in tune with some of the people that have been posting and kind of just reading up. And so just wanted to kind of gain some more information for myself.
Good. No, that's excellent. It's great. And, when I started doing minimally invasive spinal surgery, there's about 20 of us. And, I was one of the founders of the Society of Minimally Invasive Spinal Surgeons, the Less Exposure Spinal Society. I mean, all these things where there was just nobody around, and now we have, thousands of members in our society. So you've got to start somewhere, and you got to start, learning and thinking and talking to colleagues. And this is exactly how I used to get together before we had, this kind of internet stuff. We'd sit around the big meetings, just sit around the dinner table, and about 20 of us, and start to say, hey, what are you doing? What are you doing? Let's try these things. And, it's good to get started early. Anybody
I
else?
appreciate it.
Sure. Anyone else have any questions or comments or difficulties they may have had? Has anybody had a hard time with an implant, hard time with a Zip or InSpan or Minuteman or, you know, any device?
Hey, Doc. So this is Prepatella here. Thank you for what I was able to catch of this webinar. It was fantastic. Just to give you some background, I'm a PGY5 interventional pain fellow. I did anesthesia training. Thus far in my fellowship, I have got to do 2 Vertiflex procedures I'm familiar with, but haven't done the Minuteman, and really interested in kind of a clinical interest in minimally invasive spine procedures for my career. So this was really informative. I guess the question I'll say is, you know, as a pain physician, someone who only has a year of surgical training under his belt, you know, I did an internship. I know the basics of, you know, surgical care. But for someone who's not orthopedic spine or neurospine trained, question becomes, how do I identify the appropriate patients for this? And most importantly, how do I determine when not to go ahead with this procedure in someone who may seem like a candidate at first?
Okay, so two-prong question, and I'll give you a 3-prong answer, hopefully. The indications are really wide for this. So as an orthopedic surgeon, it's the same indications for laminectomies and fusions. So it's people who have, now, you know, a person who has a 35-year-old with a unilateral disc herniation and no facet problems, you know, I'm not going to do this procedure on usually. Now, if there's a huge amount of back pain along with it, I might consider it, but those are few and far between, and I try not to just operate on predominantly back pain. The big bulk of my patient population, as I think we discussed a little bit earlier before you got on the call maybe, and before I could get my video working, I apologize, is the spinal stenosis patients. So the elderly, it's a huge patient population. It's so much a part of what we see as pain management and otherwise. There's just so many patients out there. It's just crazy that are suffering from spinal stenosis. They're getting their hearts taken care of better. You know, they're doing stents. Everybody's living longer, but your spine is the only thing you got, right? And so those indications are tons. People I wouldn't do this on, that the most is a person who's had a previous surgery where they had a fusion. You got to be really careful. And I'll look at, and the MRI is difficult to read, and the X-rays are. I would encourage you to get MRIs and X-rays on everybody, okay? Especially the X-rays. You think, well, I got an MRI, I don't need an X-ray. I promise you, when you order the MRI, just click the box that says X-ray, AP and lateral along with it, so you can see what you have to work with. Because in the case of previous surgeries, you don't know how much the other surgeon chewed down. If it was an MIS surgeon like myself, I'm going to preserve a lot of this stuff. If it's more of a traditional surgery, which is the bulk of what you guys are going to see that's still out there, those guys are just doing what I call bulldozer surgery. They're just coming in there and bulldozing all that stuff out. And so you may not have enough spinous process to work with. And you don't want to get in there and get to the ligament and begin to take it down, then all of a sudden there's nothing but scar down below because they had a 5-1 fusion and you're there to do 4-5 and there's just not enough left. And then you're making a decision, well, I'm going to bite into that scar. Is there enough to distract across? So that's usually where I decide, with careful looking at the MRI, the X-ray, or if I need to get a CT because I just can't see the bones clear enough, get a CT. Don't hesitate. And look and see what you have to work with as far as landmarks, okay? There was something else I was going to mention to you, but anyway, I think that's the predominance of your question itself.
And Dr. Patel, we can certainly follow up with you with anything that you missed. We'd be more than happy to set something else up to go one-on-one with you and answer anything you might have missed at the beginning. I don't know at what point you came in, so I can't, but we'd be happy to do that if you have the time.
I'll just tell all of you all, the difference between what they're doing with KICVentures and the products we develop is that you're probably not going to have a lot of orthopedic spine surgeons teaching you how to do this. In fact, you're probably not going to have any orthopedic spine surgeons and neurosurgeons really teaching you. You'll have a rep from other companies or distributors or whatever. And as surgeons, I want you guys to know how to do this procedure. I want to be there to kind of help you. And we've got a lot of guys who have done a lot of these procedures that can back you up. You got into trouble, you're not sure what to do. You know, you had a patient, those kind of things. Again, people call my cell phone all the time. Hey, what do I do with this? What do I do with that? Or I tried this device and this is what happened. What should I do next? I don't have a lot of support in my community, but except for my other pain management colleagues, I don't have any surgeons, and they're going to, try to eat my lunch or whatever. That's just the way it is these days, and you will step on some toes, I think, doing this, but I think this is a perfectly good procedure that can be done at a pain management level and probably should be done. But you're just not going to find many companies that have spine surgeons that are willing to back you up and be there, teach you. And I think that's what separates us, because I think that's the right thing to do, because you'll be happier with the procedure and you'll know these little nuances, and you don't have to learn from all the errors and mistakes and things that we went through. Good judgment comes from what? Bad experience, right? So we want you all to have as many good experiences. Let us learn, have learned from the bad experiences and teach you kind of what to do.
And Dr. Arenas, if I can add something to that, certainly with the orthopedic surgeons having that much knowledge, being able to transfer that over. KICVentures also has a really, knowledgeable engineering team, and I'm not just saying that for myself. We work very closely with any of the users, any of the surgeons, pain management doctors that use our system. So if there's something that can be changed or something that can be improved, that's something that the team is certainly willing to look at. Because at the end of the day, I think that's what the philosophy of this company is. It's just to continue procedures, these technologies to make it easier, not only for you guys, the users, but also ultimately the patient, and getting that patient back on his or her feet, as soon as possible.
Any other questions that we can take? Because I know time is important for everybody. Anything?
I have a question. I'm a distributor in Louisiana. I have other areas. I've actually been in spine for 16 years, and I did the osteomed, I did Lanks. I actually sold the mild procedure back in 2010. So I saw a lot of these patients that you're talking about. So would you say this is competition to Vertiflex? There's a lot of other competitors out there that are kind of like going after that business, because I don't see it as that. I mean, I'm just curious.
Well, sounds like you've been around for a long time, so you probably remember X-Stop, right?
Yes.
Okay, so Vertiflex to me is a biomechanical X-Stop. It's so similar to that. It's a stopgap device. That's what it's doing. I think I'm not here to poo-poo on Vertiflex. I think it has its place. I tend not to use it because I'm usually called in to take them out and then to fix it, which is no problem. I mean, I think if you want to try Vertiflex and it works well, which it does, it just has so many limitations because it's just like X-Stop. And what Medtronic owns X-Stop now, they bought that for, I think, however much money they bought, but they don't market that device or sell that device to anybody, I don't think, anymore. But those of us that have been around for a while remember that, and this is just a different version of that. So I think each of these things have their place in your hands and what you're doing. It's just that devices like InSpan cover exactly what Vertiflex does and then a lot more. So why would you do that, except that it is a very tiny, it's very minimal. I just think it has a shorter lifespan where it can maybe work, but it has its place.
Would you do this with a facet fusion or something like that? I had a lot of doctors that did the Lanks with that, and I agree with you. Back when I did the mild, I was like, this is very interesting. All of these interventional pain doctors have all of these, I would consider intermediary patients that are not yet interbody fusion candidates, but they're on a spectrum of being mild candidates to an X-Stop if we could do it, and then maybe fusing the facets, and then maybe they would never go on to needing pedicle screws.
Great point, and you're exactly right. I tend to do more facet fusions along with this, and I think as the doctors get more comfortable, I've done InSpan and then put a small a facet screw like this, that I'll put one or two of those across that facet. But the device itself does stop a lot of motion across the facets, and as you get more comfortable opening up that facet capsule with a Bovie, maybe taking a small rongeur and then taking your graft, packing it in there, and doing a good service for the patient, because that's once that does fuse, this, as opposed to Vertiflex, this is a fusion device which holds it. It's a strong device, so it's going to stop that motion and allow those facets then to fuse together. And once that happens, you don't need the device anymore. those facets will take all the load off of the device itself. And I mean, it doesn't do it. It's just holding it there, but the facets are really doing the job once they fuse.
And have you revised any Vertiflex with this?
I have revised one InSpan, and it was after a trauma. So I think the patient had a car accident and actually fractured through the lamina and the spinous process and part of the pars. And so actually, but that's the only one. And I've used this to back up like a lot of my lateral fusions and things like that. Mm-hmm. It works quite well because it's so simple and you're not using pedicle screws. So, and you guys appreciate the damage that pedicle screws do. And, you know, because of financial reasons, there's a lot of pedicle screws being put in. But it can be done in a much more elegant way and a less invasive way. It's usually better for the patient with devices like this.
Yeah, I always say I made a lot of money, but it's not good for patients. You know, not at all. So.
Exactly. Yep.
Dr. Anagnost, I think Diana was asking, have you revised Vertiflex?
Oh, yes. Yes. Okay. A lot of, I'm sorry if I misunderstood your question.
It's okay.
I do quite a bit.
I kind of think of everything, and I have a lot of friends all over the country, and I'm hearing of a lot of this. And so I have a lot of I start to think, okay, what are they going to start coming to me? And I think about revisions, and I started on revision A-lifts, and then I was part of a startup, and we actually did the stay lift device, and I actually did a ton of Charité revisions. So I tend to think kind of about everything that can happen. So that's why I asked that question. I'm just kind of thinking if I get that call, because I hear this happening in different parts of the country from different reps and different doctors, and whether they're...
That was part of how I started working in a pain management office with Dr. Patel here in Oklahoma. You know, I was revising some of the stuff. He called me in to do that, and then we got to doing a lot more things together. And now, you know, it's been good for me because I've learned so much stuff from the pain management guys. Hopefully, he's learned a lot from me, and it's been a nice symbiosis instead of this antagonism that a lot of communities have because they're fighting over market share. I think there's a place for a lot of symbiosis between orthopedic spinal surgeons and the pain management community where we can really kind of work together and help each other. And mine's been very fruitful and educational for me too.
Thank you.
Yeah, sure. Any other questions from anybody? No dumb questions. It doesn't matter. We won't laugh at anything because we've already been there. Hopefully I'll have some answers for you. Okay. Well, if you guys need anything, you can get my number from these guys. I would encourage you, if you are interested, to come do a lab. Enjoy teaching this stuff. There's nothing better than kind of getting there and seeing it and really appreciating it. You know, be proactive and kind of get out there. And this is a great part of my practice. The complications have gone down. My patient worry has gone down. My patient satisfaction has gone up. You know, this is a great device and a great procedure.
Hey, Dr. Anagnost, how long does it take typically to do a one-level case for you in the outpatient center?
You know, it's probably 30 to 40 minutes, but I mean, an hour is very reasonable. I mean, if you're struggling for 2 hours, then probably, you know, getting a little help from one of us or getting some pointers, it won't take you long. So you're not lost in there, things like that. So, but I think an hour is very reasonable for our pain management colleagues to kind of do something like this. But usually it's like 30 to 40 minutes. Probably the shortest I've done has been 20 minutes, something like that, where it's a really thin patient, you know, get in, get out. But speed isn't too much the issue unless you're getting over an hour. You don't want to be in there too long. So we can help you, or I can help you. Anybody can help you. I'm glad to do it if you are struggling along, no matter what you're using. I'm glad to kind of give you my advice and pearls and try to make it easier for you all. All right.
Thank you, Dr. Anagnost. I think, Ratan, we can conclude.
Yeah, thank you. Thank you so much for your time, Dr. Anagnost, and everybody else who were able to join in today. We will be following up with you all individually. Again, my name is Ratan. I'm from the customer success team. It was a pleasure connecting with you and sharing with you the login information. I'll keep in touch. I'll follow up. Please do not hesitate to reach out to us for any literature, any product information that you'd like to have, I'll definitely look forward to an email from me, which will have brief information about the product. And I'll be here along with the engineering team, Dr. Anningnost. We thank you once again. You guys have a great night.
Thanks a lot. Good night.
Yeah, thanks.
Thank
Thank you.
everybody.